Greetings, everybody. I'm so proud and happy to kick off the SMSNA APP series sponsored by Endo, put on by the SMSNA. My name is Toby Kohler, and on behalf of Dr. Landa Trost and my esteemed colleague, APP extraordinaires, Kent Mitchell and Elise Fosnight, we're pleased to bring you this first session about Peyronie's disease. I will go ahead and start to share my screen here and get things going. Eventually. All right, so there are our names once again. And as we continue, again, thank you so much to SMSNA for making this possible and Endo for sponsoring this series to highlight the critical role and the importance of APPs and their role in delivering ideal treatment for sexual dysfunction. So yeah, that's awesome. We have no endo-related disclosures from our speakers today regarding their topics. And we will be discussing some off-label Xiaflex indications. So everything that we're saying are our opinions. They're not from the label, but we'll tell you what we think and how we do things. And so there'll be a couple talks given, and then there'll be some Q&A. And please, if you have any questions as we go ahead and put your questions in the Q&A. We'll try to get those answered. I'm going to turn it over to my colleague and friend and the smartest guy I know in sexual medicine, probably the smartest guy I know, period, Dr. Landon Trost. Landon.
Well, everybody's lost trust in Toby already. Like 2 minutes. I mean, this is crazy. Well, it's good to be with you. Glad to be able to join you. And I'm grateful to be able to do some brief introductions of our speakers today, because it's a very strong panel of those who'll be speaking with us. And, you know, looking through the attendee list, I see some names we recognize too. You've got Nick G joining us as well. So good to see all of those who are joining elsewhere. So now format-wise, we'll likely save all the questions to the end, only because that way we'll get through the presentations and then we can just kind of pepper questions as they are. For housekeeping items, if you have a question that you want us to highlight, put it in the Q&A and not the chat. If you go in the chat, we're just going to forget about it because it just keeps running with a rolling chat. So throw it in the Q&A, and then we'll try to do our best to address it, timing wise with it. But by way of introduction, so first I'll introduce Elise Fosnight. She, as you'll be able to see on the pages, has many areas where she's received certifications and trainings. She's a physician assistant, and she has founded the Fosnight Center for Sexual Health in Asheville, North Carolina last year. She's on multiple sexual medicine boards, including with ISHWISH and the SMSNA, and is in North Carolina Academy of PAs on the board of directors with them. So we're very pleased to have her, who will be presenting in just a minute. And then Ken Mitchell, I'm not sure he needs much introduction as far as Ken Mitchell has kind of been a stalwart landmark for a lot of physician assistant projects, in particular relating to men's health, definitely a stalwart in that regard. He recently joined Arkansas Urology, where he's been in men's health in total for nearly 26 years at this point. He's the now Ken, is it past president of the UAPA or current president of the UAPA?
Past president of the UAPA.
Past president. He's ancient now. I shouldn't even bring that up. No, but clearly had many very significant roles there. And then he's been the chair of the membership committee for the AUA for APPs. So very high level roles. And then of course, everyone, Toby Kohler doesn't require any introduction at all. He is an andrologist. Currently works at the Mayo Clinic as a head of andrology there. And has many leadership roles, both at the SMSNA as well as AUA, and is a good friend to pretty much everyone who meets him. So clearly world recognized expert in sexual medicine. But yeah, and I think we all feel very similarly, the role for APPs is very significant. And in fact, if any practice does not recognize the importance and role for APPs, they're behind the times without a doubt. We've been able to integrate APPs in our practice early on at Mayo to where they perform full surgeries of anything that we perform. And for those who've been watching in Utah recently, they passed a law where APPs can practice independently without any supervision. And once they have 20,000 or 10,000 hours, maybe 10 or 20,000, I can't remember, hours of experience, they no longer require an MD supervision. So the trends in the United States will continue to go that way, and independence will continue to grow. With that, I'll turn the time over to our esteemed colleague, Lise Fosnight, who will go ahead and present her talk on Peyronie's disease.
Well, thank you so much, Dr. Trost. I appreciate that lovely introduction. And I am super excited to be here talking with you all this evening. And hopefully we'll be able to shed a little bit more light about the collaborative roles that APPs can provide, especially in all fields of medicine, but especially in our specialty roles within urology and the Peyronie's disease. All right, I'm gonna see if, oops, I do have control over the slides. All right, good deal. So I wanted to start off with being able to talk a little bit more about risks and benefits when we're talking about different treatment options for Peyronie's disease. This is going to be really important when you are discussing treatment options with your patients, as well as, again, with your team. Again, making sure that your patients have a really good understanding of what their treatment options are, and those risks and benefits as well. So what I normally do, I kind of gave you a little bit of a list here of all of those different medications, because this is what I actually have in my exam room in order to just pull out, be able to show the patient so that they have something in their hands that they can see. For me, one of the biggest things when I'm talking to my patients and counseling them is really making sure that they are able to visually see what's going on. If I say a word or spit out a medication, right? They're trying to process in their head, okay, wait, what is that? And how do you spell it? And what is going on? So when we're thinking about that, this helps to break it down a little bit easier. But when you start talking about risks and benefits, I really go to this kind of box here on the side. And what are those things that we should be thinking about, right? What's going to be the goal for that individual? How motivated are they going to be if we start giving them a whole bunch of stretching exercises or taking different supplements? Is this something that they are going to be able to follow through with? Do they have a partner? Who is their support person? Oftentimes we know that Peyronie's disease can be a very lonesome disease, very isolating as well. And so I really like to know who is their support person, who's going to help them through this process as well. And then obviously cost, is this something financially that they're going to be able to take on? Is this going to be something that they have to take a loan out for? I have had individuals do that for the collagenase interlesional injections before, right? So those are all of the things that I take into consideration too, and that's definitely a risk that we want to consider too. And then, right, what's the degree of their disease? What's the degree of curvature? Where's the location? Are they inactive or are they in stable disease? And are there other overlapping medical concerns, especially with erection issues that are going on as well? And we can consider ED, premature ejaculation or delayed ejaculation as well. So again, I always try to start with kind of least invasive and move towards those that are going to be more invasive types of interventions, such as surgeries. The other thing I like to talk to a lot of my patients about are what are those FDA non-approved options also, right? They hear these on social media or they're seeing an ad for it someplace, or the men's clinic down the street, the concierge service or the aesthetics place, right, is looking at advertising some of these options. So I've got to make sure that I have that on there because I know that they've heard it from somewhere, and I want to make sure that I'm going to be up to date with what's going on there too. And then this is going to lead me to this next slide, maybe, there we go. On kind of like, then how do I set it all up? So I probably, if you can't tell, have never met a stranger in my life. I have always been a peer mediator. Counseling has always been a part of my role as a PA. And when we're talking to our patients that have been diagnosed and assessed that are now having that diagnosis of Peyronie's, right, it's going to be that counseling piece of it and how do we help them through this process. And so again, when we think about desired outcomes, this aligns a lot with their goals as well. So making sure that we are taking into consideration the patient, right? They are just as much a part as this team and need to play a very active role in the decision-making and knowing what's going on as well. Making sure that they understand, who they are, what their health profile is going to be, And then also talking to them about what their values are. I have individuals that I see. I'm in Asheville, North Carolina, so sometimes we can be very crunchy and granola, and people want to be able to have some homeopathic types of influences. So I need to know that. I need to talk to them about, again, what their hopes are in getting better with this disease is as well. And then making sure that the information that they have is going to make sure that they can make an educated decision on minimizing that risk as well. What about the healthcare provider side of things, right? We have to make sure that our individuals are understanding those risks and benefits that are being recommended, as well as, again, like we said, those alternatives, adjunct therapies as well. And then as a healthcare system, we have to make sure that overall and globally that we're providing optimization of the healthcare treatment through the Peyronie as well. So not just my patient in front of me, but looking again in totality of all of my Peyronie's patients and what's going on with them, and are we seeing any trends, benefits, or bumps in the roads. Now, what about guiding principles, right? Again, this goes again with all of the counseling that you are going to be able to do. Counseling has to be necessary for everybody, and it has to be something that, again, is ongoing. It isn't something that you can just do or tell them in that first visit, right? We have got to always be talking to that patient about how things are, evaluating what's going on. And again, it has to be collaborative. So not just collaborative with the patient, but also with other team members. And we'll talk about who else in my next slide that we might pull in as some adjunct therapy as well with those. It has to be very individualized. So everybody doesn't fit in this one size fits all box. Making sure that, again, it's going to meet the needs of that particular patient, and that we can't just use kind of a shotgun approach when it comes to that counseling. And then last but not least, right, it has to be evidence-based. We want to make sure that whatever treatment options that we are talking to them about, or those risks and benefits, that there is some evidence behind those different treatment options. I like to take that into kind of what our counseling elements and those best practices are as well, and we call those the 4 E's. So we're looking at evaluating, again, looking at that patient's health profile, we're educating them and making sure, again, what are those risks? Is this something that is going to be okay with all of the other medications that they are taking? Are we concerned that they're going to have a bleeding risk because they may be on some anticoagulation therapy? We want to make sure that they're engaged in this too, that they're just not sitting back. I tell my patients all the time that we're a team, right? We are walking on this journey together, and I can't do my job if you aren't doing yours, and you can't do your job if I'm not doing mine. So we have to make sure that the patient is always continuing to ask questions, be engaged in those conversations, and again, making sure that they understand what's going on. And then that goes back into the insurer, right, is the understanding of what's going on within those patients. I use an implementation on this next one for that insurer. I love teach backs. I ask the patient all the time, what did we just talk about? What is your understanding of the things that we just discussed? What questions are going on in your head? Tell me what we just talked about. And if they're struggling with that, we may have to go back and do some re-education. We know that time is of the element, and so a lot of times we'll do some stage discussions. If you all have the luxury, kind of like I do, with being in a private practice where I get to spend an hour with my patients discussing their Peyronie's diagnosis, the disease process, the risk and benefits of all of those treatments, that's great, we can do that, but I recognize that some of you all don't have that opportunity to do that. And so you may have to come in and say, you know what, we're talking about all of these different options. Here is a handout, the resources. I want you to go home and think about what those options might be. Let's get you scheduled back in a couple of weeks or a week if, again, you're able to, or you have that availability in your schedule, so that now we can talk about it. The great thing too about telehealth now is we can do a lot of virtual appointments. And so that's been great. And I've utilized that to help to supplement so that people don't have to come in all the time. So we give them all of the information. I've done the physical exam. They're there in the office. And now I say, you know what, let's do a virtual visit in a couple of weeks to talk about some of those questions and those treatment options that I have just given to you. Okay. So when we think about adjunctive therapy, we want to make sure that you are utilizing all of the members of the team. I feel like so oftentimes we get a little pigeonholed in just our little clinic that we forget to think about the other avenues that we have out there to maximize the benefit of our patients, especially with Peyronie's. So I'm a little biased with pelvic floor physical therapy as a female that has birthed 3 babies. I completely understand and completely give kudos to that pelvic floor, right? But everybody has a pelvic floor. Men have pelvic floors. And what I find that happens on a lot of my Peyronie's patients is that they're very anxious. Those anxious individuals have very hypertonic pelvic floor muscles. And so what's happening is they're having sometimes pelvic pain, they're having some urge incontinence, some bladder issues, some defecation issues as well. And what happens is when those muscles get retracted, they can pull in, they can cause penile pain. And so I will oftentimes refer to my pelvic floor physical therapist a lot of times before we even start treatment to make sure that there aren't any discrepancies in their pelvic floor ahead of time. But the way I utilize them in Peyronie's disease is, especially if we were doing any penile injections or direct lesion treatment, it's really good for them to do all of the teaching with the stretching and modeling exercises afterwards. There's a lot of techniques that they can do. There's a skin rolling technique. Again, we're talking about inflammation and scar tissue that's in that area. So they're able to mobilize those fascial structures as well, and that can be really helpful. When we think about ED as well, and that hypertonic pelvic floor, it's limiting blood flow. It could be inhibiting the nerve sensitivity to the area too. So by able to lengthening those muscles and again, allow them to function like they can, you're getting optimization of that pelvic organs. We know that there, again, is a lot of emotional component to it. Again, it's very isolating. It's very shameful. There's a lot of stigma around it anyways. So I utilize a mental health provider. We are very lucky to have 2 sex therapists in the office that are very familiar with Peyronie's disease. And again, for couples too, right? That can be a really big thing as well in there. Like I said, too, I have lots of individuals that want more homeopathic types of options or adjunct. So I tell people all the time, listen, you know, it may not be as beneficial as we would like to for just utilizing one treatment option. So we want to like multifaceted, get it all layered in there so that, again, that combination therapy is going to be your best option. Using a nutritionist for any anti-inflammatory diets can be really helpful too. And then, right, so make sure that you're not alone. There's support groups. This has been really helpful too with this new virtual age. I know sometimes we get a little Zoom fatigued, but at the same time, it's really great that you can connect with other individuals around the United States for these support groups. And that can give you a lot of information for that patient too, and a lot of educational resources as well. So again, utilizing a team approach. Again, we use more of what we call like a biopsychosocial approach to treating Peyronie's disease, recognizing that it's not just the medical individual and those medications and prescriptions for the surgeries that can be implemented. But again, that is the mental health component of it as well. All right, I will turn it over to Ken at this point.
$10,000-foot view. There you go, you got me now. More of a 10,000-foot view, if you will, the APP role in optimizing patient care and mental health. I have had the opportunity to consult with multiple practices, and as a result, have just gained a lot of experience, not only in my own practice world, but also in others, and some of those unique challenges that come along with that. Let's see if I have control. Slow. So this might be my fault because I have transitions. So one of the things that's really important to understand is that there is a lot of variability in the utilization of APPs across practices, and it can range from inpatient to outpatient roles. And a number of things play further roles in that. State practice legislation can decide how much you can do. Governing bodies may have different rules about your practice legislation. Payer requirements, billing preferences, practice preferences. It was mentioned earlier, you know, the 2 physicians that are on board here today that are on this call, they are early adapters of APPs, and there are a lot of practices who are still trying to make that change. And so their practice preference in and of itself can be a challenge. And then once you're actually in the practice, whether utilized independently, having your own schedule versus a tandem schedule with the physician that you're working with. I think there are some key principles that are getting started, and probably one of the biggest pitfalls that I see when an APP is joining a practice, in particular in the men's health space. Oops, I don't know why that happened. And I don't know how I can go backward. There we go. It's very important to identify and understand the needs of the men's health patient, and then understand that within the scope of that practice, make sure you can identify what your role can be in meeting the needs of that patient. And again, that is probably the biggest mistake that's made, is the need is never identified. And so you're kind of winging it. And when you're winging it, it's just a bad message that you're sending to the patient. It almost makes you look somewhat incompetent in many ways. It makes the practice look incompetent. Your role as an APP also is understanding the role that the MD, DO plays in that patient's treatment course. And once that's understood, then it is critical that you create a plan and how that need is going to be met, with the patient's needs being really at the top of the list. And then making sure that as an APP, you do support the role of that MD, DO in meeting the needs of that patient. And let's see what happens there now. Well, I went from I can change to now I can't change. There we go. All right. So I've often said, back in the day, APPs were often called mid-levels. And, I would say there's some truth to that. We are a bridge between the physicians that we work with and the patients that we treat. Added a second bridge, and that is also to the clinical staff. And so we really have a very, very unique role, which really, as far as this partnership goes, it's really to achieve the general goal of reaching the desired outcomes for these patients. The other thing I'm often asked about this whole role really is, how can you make yourself valuable? Nobody gets to do anything for free. And oftentimes I've seen where a urology practice may not even find the service line of men's health to be all that important, and they can be somewhat standoffish to the urologists themselves. And so I always kind of say to the APPs, understand what all of this really means, and that there's an opportunity cost for the urologist to have you on board. And so there's some representative numbers there, just saying that typically if you're utilized as just a hospital APP, you may not collect a lot of money, and you may not even really be paid a lot of money. But really what happens is that it's both a quality of life, but also a business decision, in that the urologist no longer has to worry about missing clinic. Patients get addressed if you're involved. And what should happen really is that you, practicing at the top of your license, will be able to provide care at a high level for your scope of practice, and then also allow the physician, urologist, to go ahead and move forward with doing the things that they have been uniquely trained to do. And they're really outside the scope of your practice. And so it should free those things up. And I always say the best metric to look at is that if you look on the day that an APP is hired in a practice, if that APP is doing good productive work in the treatment of men's health patients, just for the sake of this conversation, what you should see is an uptick in a higher level RVUs, both in number and in type for the physician that they're working with. And then just on a more global scale is that you will improve the most important things, and that is meeting what I like to call the quadruple aim, and that is, in your community, you're going to do better population health. You're going to improve the patient experience, which is also very important just for our service line. As it's been mentioned, there are a lot of clinics that are out there that don't really provide optimal care. They do a lot of non-FDA approved treatments. And if we can represent the service line and provide good care to our patients, again, it will play a role in the overall community. It is a sustainable cost. We're less expensive than physicians. And then frankly, what that does is allows the physician and the clinical staff, for that matter, to not suffer from burnout. And then it's often talked about from a business perspective as the iron triangle, which I've often laughed and said to every people that, the iron triangle is the cost, quality, and access, which is necessary to provide care. For every straight line in that triangle, an APP represents that bend that puts it all together. So clinical training is another important piece, of course. And it can oftentimes be the most challenging piece. I've been fortunate, physicians like Toby Kohler, and I can name countless others in SMSNA who reached out to me and were available to me to make sure that I was clinically trained to provide the best quality care for the patients who come in for particularly these men's health conditions. I have a background in general medicine, and so for me, there was a bridge of knowledge with the underlying causes of a lot of these things. They were things that I have treated, which many of us as APPs have that skill set or have that experience, and that makes us an added value to taking care of these patients. Once you jump into the realm of surgical subspecialty, then you really do have to make it a point to be clinically trained in the perioperative management of the male sexual dysfunction procedures that are often performed. I have also recommended too with clinical training, getting it from your physician is really important. But for all of us APPs, as Landon described me as ancient people have to go out and be mentors to all of the other APPs that are out there being thrust into this role that's new for a lot of practices, even in 2021. And so what I like to do is kind of give this sort of graphic depiction of kind of how it all sort of comes together. And as in a practice, typically there are both internal or self-referrals that come into the practice outside. And then there are external referrals that come from other practices. And so that always leads to good patient assessment, evaluations, et cetera. And then really on this side of the diagram, the medical management consisting of office visits, ancillary things like labs and imaging that need to be done are things that really we are really going to be responsible for. But what happens really in this case is that a patient may turn where he has failed medical management or can't no longer really function in the ambulatory care setting. When that happens, that is when surgical management comes into play, and that goes into the hands of the experienced surgeons that we work with. And then ultimately what happens really is that we set a pattern of care, if you will, that both the patients understand and the practice understands, where we get optimal APP utilization. And then eventually, and what we do is optimal utilization of the urologist in that same setting. And so all of the patient's needs really could be met if this type of understanding, if you will, or practice pattern is what's oftentimes is both developed at the outset and then allowed to organically grow into whatever the needs are that the practice evolves into. With that, I will stop. Thank you again for having me tonight. And then I believe, Toby, you are up.
Gotta unmute. Rookie error. Okay, so thanks so much for those informative talks to both of you. I'm going to take a few minutes here to go over some successful workflow and best practices points and some take-home points that I think are important to counsel your patients about. Just remember that Xiaflex or Clostridium histolyticum collagenase has a grade B evidence. It's the highest evidence to have an efficacy when you're doing intralesional injections. So that means this is moderate evidence, and the other is kind of weak evidence for the other players. Look at the graphs here showing how surgery has been reduced and injections have been coming up since injections have become a thing. And this is only to 2016, and I believe this line continues in its current pathway. You know, here is a summary of some data. It's a very busy slide, but the bottom line is the following. When you look at change in penile curvature from the initial Xiaflex trials, you see, a change in curvature by 17% or degrees average. And you see if verapamil really didn't do anything in this study, these are the only 4 randomized placebo-controlled trials, by the way. Interferon worked a little bit, but not as well as Xiaflex. And so, yeah, Xiaflex has the best data, and that's why the guidelines support that. So, when we look at specific studies, this is the big one, right? And you look at the composite curve improvement or composite responder, we see that indeed we see an excellent improvement compared to placebo, which is really important. And then this composite responder score is kind of a created thing where it talks about either 20% greater penile curvature reduction from baseline or an improvement in their PDQ assessment, or going from not being able to have sex to have sex. So like meaningful change. And you see this increase relative to placebo. And of course, I think most of us are familiar with the current treatment protocol, which involves 2 injections per cycle for a total of 4 cycles. And whether or not this is the ideal treatment cycle is certainly debated, and people experiment with different variants of this. We continue this variation at the Mayo Clinic. And again, you see, you visit 1 collagenase, some kind of waiting period, whether a day or up to 7 days in our hands, and then wait 4 to 6 weeks and repeat 4 times. And in the meantime, we've discovered that modeling, whether it be manual modeling from the patient alone or using traction devices, are essential in improving outcomes. So here you go. Here's some pictures step by step. So for every XIAFLEX that's done in Rochester, and this is largely Landon's doing, and I think it makes a lot of sense, we perform an artificial erection for every time we inject XIAFLEX. We feel if we're going to optimize the medication's efficacy, we want to know exactly where the point of max curve is. So every time we get XIAFLEX, the guy gets an artificial erection. Then, for the first couple, and when you're doing trials, you're going to obviously want to measure the curvature and that you can assess progression. You're going to find that point of max curve and then inject into that plaque. And, the sign that you need to see if you're injecting properly is a indentation on your thumb because it's so difficult to get this medication in. If the medication just slides in, you're probably in the wrong spot. And that's an expensive kind of distribution of the medication probably into the corpora. So you really want to make sure that there's a lot of resistance when you administer this medication. And then finally, super important, you got to put the correct type of dressing on there. So if you don't put a compressive dressing on afterward, and notice how it kind of goes over the part of the glands here, you're going to get distal swelling. And sometimes the patients can, get significant swelling and bruising and bleeding. This goes a long way in helping prevent that. So again, the take-home message that I want everybody to understand from this is that I think it's really important to deliver an artificial erection each time you give XIAFLEX to optimize where the treatment goes. And, Ken just talked about the role of APPs in, triaging patients, but, our APPs at Mayo, they're the ones giving the XIAFLEX for the most part. They're doing vasectomies, they're doing cystoscopies, they're doing procedures. So I'd encourage everybody who's on the call who is an APP currently or is considering being an APP, stretch yourself, become indispensable, learn how to do these procedures so that indeed you bring additional value and you'll be an indispensable part of the team and be very marketable for your next practice. The other thing that's just super important is after you give these injections, the patient has to do manual modeling. And so you can see here, this patient presumably has a dorsal plaque. So he's going to bend the penis in an equal and opposite direction by creating a fulcrum with his finger underneath and just bending the penis down every time he urinates. This, in combination with Restorex or stretching devices, is critical in achieving not only the initial results we saw before, but much better results. Indeed, there can be side effects, and I think we'll get to some of these later. But for the most part, if you do a good P&L wrap and good counseling at the time of the procedure, it's not going to be that obtrusive in your practice in terms of side effects. This is a very busy slide, but basically it goes about some of the studies, and I'm going to go over some of them individually. So this is the first study by Dr. Ziegelman out of Mayo after the IMPRESS trial for the clinical data. And what I really want people to see is that when you talk about meaningful improvement, the patients are delighted by the majority of the time with XIAFLEX. So critics of XIAFLEX will say something, well, hey, the mean improvement in curvature was only 18 to 22 degrees. Well, guess what? Even a 5-degree improvement in curvature is meaningful and noticeable to the patient. And if you ask the patients, did this restore penetration? We see yes, 55% of the time in this particular cohort. And did it prevent surgery? Yes, greater than 50% of the time. So even though the degree of curvature is maybe not that impressive at first glance, it totally changes the game for these patients in terms of being able to have sex and being able to prevent surgery. When we look at the type of characteristics, which are probably ideal, our opinion is that a curvature in the 30 to 60 degree range is probably best. Duration of disease, I would dispute this. I think it works regardless. I'll get when the time course is. Baseline sexual function a little bit better is probably ideal. And then plaque calcification, the less calcification, the better. That's true. So what about injecting in the acute phase. Again, this is off-label, so typically you want to have stable disease, right, when they first did these trials. But when we looked at actual data of men of like this multi-institutional set, about 15% were in the acute phase, and they did just fine, and they had excellent responses in their curvature. And in my mind, it's like, why would you let the curve like establish itself and calcify when we know we can't treat it as well, when you can treat it earlier and prevent progression, right? So we routinely give Xiaflex in the early stages. And so when you look at plaque calcification, we see here that the more white plaque you see on penile Doppler, which again, all is done primarily by our APPs in Rochester, the worse calcification there is, the less likely you are to have a response, right? So if you have a turtle shell in the penis, which is like giant bone area, it ain't gonna work. But the less calcifications, the more likely you're gonna have success. What about combining, your injections with traction? So we saw just crazy improvements when we use consistent traction. Now, Restorex is a device that Dr. Trost designed, and it's able to provide a constant traction of the penis, which is adjustable for the patient. And so, it's a great thing. It really helps in both curvature correction and length improvement. So if a patient comes to you with this goal of also restoring length, Xiaflex alone is sometimes not as effective, but when you combine it with the traction therapy, specifically Restorex, it works awesome. What about ventral curve? Well, it works just fine. And, the initial thoughts were, hey, this is going to be, somehow you're going to inject the urethra, it's going to be bad. When we looked at our series out of our Mayo Clinic, again, we saw that the adverse events were essentially identical for both ventral and non-ventral plaque, and the improvement was very similar. So yes, this can be used for ventral plaques too. Again, off-label, but totally works. And why wouldn't it? There's scar on both the top and the bottom part of the penis. The collagenase works equally effectively. So in summary, my thoughts, Xiaflex, the ideal candidate is the 30 to 60 degree curve. Fixing an acute angle as opposed to like this banana sloping curve. Acute angle, it has a better response, but the slow banana curve can be treated as well. Severe indentation, not awesome, Xiaflex in our hands, but when you combine indentation with Xiaflex and traction, now you're talking. Always use penile traction in modeling. We use it in both the acute and chronic phase. It is reasonable to reassess after a few cycles to see how things are going, although we're just publishing a paper showing that even if you don't have success after the first couple cycles, there are many men who get success after the third and fourth cycle. So probably should keep going. And then if they primarily have a pain indication as opposed to a curve indication, then Xiaflex is probably not the best first choice. You can consider something else. All right, last slide here, billing stuff. So, in 2021, there were unbelievable changes made to billing. And if you guys don't know about these, your life was made incredibly easier since January 1st of this year. Currently, if you are seeing an established patient or a new patient, that is a Medicare patient above age 65, which cannot be considered a consult, you don't need any history and physical. Essentially, all you need is medical decision-making documentation. So that is crazy in terms of how much time and effort you need to spend documenting. So learn those rules. It's totally worth it. If you know billing, you can work smarter, not harder. The next big point here for billing stuff is contact your endo rep. They have all these resources which you can take advantage of if you get in touch with them. So they have great teams out there ready to help you and your patients. They have this Endo Advantage plan where you can help ensure insurance coverage. And in general, the billing and coding for Xiaflex is pretty straightforward. When you're giving these injections, you're billing 54235. Sometimes you throw a modify on there if it's a second visit. And then the third visit you can't bill for modeling. And then the other thing I would say is, even though the billing and documentation requirements have changed, it's very essential that you document these things in your note: diagnosis, date of onset, degree of curvature, whether or not you can palpate the plaque on physical exam. The answer is yes to that. Prior treatments, presence of pain, other relevant clinical information. If you include this, the chance that it gets covered on the first go is much, much higher, right? So know your rules, but also know the buzzwords that you need to include in the chart so that to make sure that your patients end up getting an unnecessary bill. All right, that's it. And I will turn over control next to Landon, and we can go over Q&A questions from both the Q&A section and some of these questions that Landon came up with ahead of time.
All right, well, great job, everybody. What a great summary of both the role for APPs as well as the importance of all the psychological side of it, as well as thanks, Toby, for going into the billing piece. I think right now we already have 3 questions that have been sent in specific to billing. So I think that's one that hit a nerve and brought up, a few questions. So maybe we'll jump to those first. Really to anyone on the panel. So Amy Perlman has a few questions here. Does insurance cover if you use it in the acute phase or in ventral curvatures? What's been your experience so far in getting coverage for these? Ken, maybe to you first. Have you had any, what's been your experience on that? Or have you treated acute phase and ventrals?
Well, now that I'm in the beautiful state of Arkansas, that is frowned upon. So, yeah, the payers are really not fond of that. So getting reimbursed is very difficult here. Have been other places where it's been done and it's covered, but not where I'm at now. I've always wondered about, the acute phase. It's tough to get a real clear history on a patient, so I'm not really sure where they really started. When we start talking about what we consider the acute phase. And so generally speaking, for me, if a guy's been greater than 6 months, he's not having any pain, I think that's reasonable to go ahead and proceed with that. So,
Elise, how about you? What's been your experience on that? Have you had any run-ins with payers and some of the details in North Carolina?
Yeah, absolutely. So I have done some acute phase injections, and I haven't had any issues with getting reimbursement on those. I did want to kind of mention too, when we talked about if we can get them in on that acute phase, I don't see us using as many cycles of XIAFLEX either, right? Because you're getting in there really quickly. That fibrous tissue has not set up, that plaque hasn't set up yet. And so that's one of the things that I have noticed. So I would, vouch for getting in there as quickly as possible, but we haven't had any issues on the payer side of things. I haven't had any ventral plaques that I have done any XIAFLEX with, so I can't speak to that. I will say on the payer side of things, right? So you can pay for the first 2 injections, and then typically when they come back into the modeling, that they're in that global period and we can't. On my side though, because I send them all to my physical therapist, we don't have any problems getting that reimbursed. So that was one of the ways that we can kind of get around. So again, if you have that opportunity to employ a physical therapist, a pelvic floor physical therapist that works with men, that's been a way for us to kind of increase our reimbursement, get some RVUs in there, get some money flowing that we typically wouldn't have.
Yeah, great. Hellstrom's data showed acute phase that, yeah, it's definitely not any worse. So there's no harm in doing anything in the acute phase of things. But I think you're exactly right as far as every insurer is completely different, and every state is different, and every insurer is different every month. So if you really follow closely the requirements, in fact, our XIAFLEX sheets that we have now, we have, well, for United, we need this. For Blue Cross, we need this. For Blue Cross of North Carolina, we need this. And so we have these real detailed sheets, and it's just the way it is right now. And XIAFLEX in particular is under the spotlight from an insurance standpoint. So
yeah, I never move forward until I get that A-OK and green light from my billing coding person who's done that prior authorization ahead of time.
Yeah, that's super important, and we've been very fortunate thus far, and in getting these both the acute phase and the ventral phases covered. But you do need to do your due diligence. But it's like, until somebody starts doing it, starts showing data that it's effective, it's never going to get approved, right? So you're in this difficult spot. So I'm, thanks to the people who are, have the courage to do that and are published on their outcomes. And so far they've been very positive. And so I think it's just a matter of time before these become hopefully on label. But, I totally agree with the sentiment that you need to do your due diligence and make sure that the patient doesn't end up with a bill.
And sorry, go ahead, Ken.
I was going to chime in. I said worst case scenarios. We do actually have one payer whose requirements supersede the law. So you literally have to have a physician in the building with that particular payer just to do an injection. So you literally, I can do 99% of them in my clinic location, but I have to take that small percentage of patients to the facility where there's a physician in the building, which supersedes the law. So to your point, the sheet is a smart thing to do. We just do the same thing, and we'll be implementing that here as well. So.
On ventral curves, interestingly, a lot of the insurance requirements will say it can't have urethral involvement. And technically, Peyronie's disease never has urethral involvement. There's never been a documented case where it goes into corpus spongiosum. So that one's usually pretty easy to get around. And you can always go back to the original trials or any of the publications we have out there on it showing that it's been used in that type of setting. But yeah, it's tricky. There's new requirements all the time. There were a few questions out there that say, want to confirm that you're injecting XIAFLEX into the erect penis. And so has anyone else had experience in doing that? Toby, I know you and I have. Elise, Ken, how about yourself? Have you done anything where you've injected during an erection?
I have not.
So we started doing this at Mayo. We haven't published it. We just ran out of time to publish it, to be honest. But we found that the point of max curve moves during a course. And so you may treat one section and then suddenly it's a different area. And if you keep injecting that exact same spot, you're wasting at least half the injections, if not more. And so we started implementing an erection every single time in order to really see where you need to inject. We tried ultrasound guidance, we tried palpation, we tried marking it, we tried doing distance measurements, all of that. And we found nothing was as good as just doing an erection every time. The one caveat, sorry, Toby, go ahead.
Yeah, I was just going to say that, this is not an 11 out of 10 erection, right? So this is an erection that is still, maybe a 5 or 6 out of 10. So it clearly elucidates the point of max curvature, but it still gives you the flexibility where the plaque is not kind of thinned out. And again, that kind of feedback on your thumb when you're injecting is so important, because if you're in the corpora, it's just going to slide right in. But if you're in the plaque, you're not going to have resistance. So that has to be your guide. Go ahead. Sorry, Landon.
No, you're good. Well, and it's a lot easier to get it into the tunica too with an erect penis because it just flattens it out. It makes it a lot easier to hit the area. We did stop doing erections on the second of each series because I found our hematoma rates were a lot higher, because now you've got this perforated area from the first injection and then you give them an erection and you get all this blood just like pouring out. So we do it with the first of each series now, just to make sure that we know where the curve moved. But the second we've stopped just because we've started getting just better control of hematomas. I found if you get a hematoma, it hurts so bad that they don't end up doing any stretching with it. And so then you almost waste that cycle to some degree.
I'll make a comment to what Toby was talking about. Oftentimes when we do the assessment, we may not give a full dose of Prostadil, for example, but use a constriction ring to get the full erection. And then, so to answer your question, probably better, they were sort of not fully detomesed when I've injected in the past.
Yeah, that's great. David Miller also asks, can you bill for the injection of Prostadil as well as collagenase? Anybody have experience on that? Elise, maybe you first.
Yeah, I don't get reimbursement most of the time for it. So they want me to, charge one or the other. And so a lot of times I charge for the XIAFLEX injection and just eat the cost of the ICI.
Yeah, Ken, how about yourself?
Same. And if I recall, even if it's a Medicare patient, you just charge them for the injection. I believe you only do it one time in their lifetime, but you can bill for that. I mean, so no, I never charge for that injection.
We have some payers in Utah that if you do charge for it, they will never pay you for XIAFLEX on that patient ever in the future, because they will link it together as a sexual dysfunction, which won't be covered compared to as a Peyronie's disease side. So yeah, so you do have to be careful with that injection code. I can't recall ever getting it reimbursed either, and in some places it's really expensive. You can't use compounded. You have to use straight Caverject or Edex with it, and it gets really, really expensive. So let's see. So another question on, have you seen men, this one goes back to probably 40 years discussion. So do people develop Peyronie's disease from intracavernosal injections? So you're doing ICI for ED. Does it develop Peyronie's disease? Toby, maybe starting with you, what's your thought and opinion on that?
Yeah, I hate to blame the medication. I think you have men that are trying to have sex with suboptimal erections, And they're obviously at risk for that since they need injections in the first place. So it's the trauma they experience from suboptimal erections that leads to the curvature rather than the medication itself. I think historically in the literature, Trimix has been a worse offender than alprostadil for the curvature. But again, you give Trimix to guys with worse erections. So I think it's more the trauma. But we always counsel patients about the risk of curvature from ICI for medical legal reasons. But my personal bias is that it's not the medicine.
Ken, what do you think?
I would agree with that. I've asked the same question. What was the dose of whatever you gave them? Was it an optimal dose? So I agree with that 100%.
Elise?
Yeah, same here. Yeah, it's just a suboptimal erections and the trauma that's associated with penetrative activity. So. Yeah,
it's funny because you'll have patients who will attribute it to anything. They'll say, well, it was the catheter. Ever since I had the catheter, I have an up curve. And, but it's been one of those debatable things for a long time. The other side of looking at it is, well, all right, let's say you don't do intracavernous injections. What's your option? I mean, it's really an IPP. And so let's say it did cause curve, even a worst case scenario. Aren't you better off getting erections, even if it did develop curve, compared to you have no other alternative but an IPP anyways, which would treat the curve and the erectile dysfunction with it. And really what I think probably happens is they've had ED for several years. They finally do injections. They finally get their first erection in a long period of time. And sure enough, there's curve there. It probably has developed a while ago when they first were starting to get ED, and they're just now recognizing it with it. All right, good question on what is your experience in patients with deformity but without plaque? Does anyone have any reservation in treating someone with Xiaflex who has curvature? And maybe we'll define deformity as curvature first if you don't have an identifiable plaque. Elise, maybe you first.
Yeah, I was gonna say I don't ever treat with any intralesional injection. If somebody has a deformity, I usually will start them, again, I send them to my pelvic floor physical therapist. We talk about stretching, traction devices, and those sorts of things. But yeah, I wouldn't inject.
So if you have like let's say 90-degree bend, well, let's say 90-degree dorsal curve, banana-like curve, congenital penile deviation type thing, no injections for it.
Yeah, I would work on some traction to see maybe if we can gain a little bit less curvature at that point, then reassess. I'm going to ultrasound to see if there's anything specific that we could, see in there whatsoever. But yeah, it almost feels like just blindly injecting, like what am I injecting? At that point, I would feel like it's more of a plane that I would want to inject. And so rather than just having one area of that plaque where you're injecting, I would want to do almost like a series of injections. But again, that's just kind of my thought and some of the patients that I've seen, but I haven't done a plain kind of injection like that.
Ken, what do you think?
Yeah, I've not either, but I tend to default to imaging at that point if I can. I'm trying to what is really the issue here. I've seen a couple instances of some pretty severe fibrosis that's caused the problem, and so I tend to be more conservative in those patients with traction device. Still, jury's out on oral medications in those cases, but then I really do tend to go to more, again, mechanical therapies at that point.
Toby, what's your input?
Well, I think it's because of what you taught me that we've had some success with congenital curvature. So I think we're trying to push the envelope, but I think the key is the traction combination with any of these treatments, right? You have to try to start to break down the tissue, but then this is mechanical traction, which is very important. So, we do try to do it, but you do have to have a target, and you should have some resistance to the injection. If it goes in pretty easy, then I'd be hesitant to try it again if I don't think I can get into the right spot.
Yeah, someone was supposed to publish that years ago at Mayo. I forget which resident it was that had it with Candace, but we looked at the congenital penile curvatures and compared it, and we found if anything, the outcome was better in those men. So it is a viable option. It comes down to insurance again. I mean, insurance rules the world. As much as anyone thinks that doctors make any difference on all insurance for sure. Okay, let's see. Gilbert has a good question. During initial assessment, do you perform the ICI to assess curvature, have them bring in a picture, or do you wait? So in other words, do you do it all at once? You do the assessment, the ultrasound, Xiaflex, or do you kind of stage it and break it up in things? Ken, maybe starting with you.
really for insurance reasons. We're always going to do, some sort of injection to assess the curvature. We've also historically have also gotten, a shim, for example. So if we know they have ED, sometimes we may go ahead and get a Doppler, depending upon the history of that patient, get the curvature, then see if there's anything, vascular going on with their erections. And then that gives us a little bit of lag time. We can get a prior authorization done. So sometimes by the time they get in front of me, all that stuff's been done. And if we want to start Xiaflex, we just go ahead and do it right away. And that's pretty common how we will handle that. If it's not a case where the guy doesn't have ED, then we'll take a picture. Our EMR actually lets them upload it securely, so we can actually see it and pull it into the chart and look at it and go from there. But still, I would, sight unseen, I would still induce an erection before I started treatment, and again, insurance forces me to do so anyway.
Yeah, well, exactly. Elise, how about your experience?
Yeah, I like the staging piece of it, right? Kind of coming, I have usually them come in, as a new patient, we do a history and physical. Sometimes they're not prepared to have an ICI during that time. So I always let them, to defer that, and we schedule that for another time. But, we always talk about the importance of having that documentation and having that actual visualization. I can, especially if we're going to do Xiaflex, right? We got to make sure that it's greater than 30-degree curvature in order to get that approved. And so, I'll see them. Again, a lot of times they want to defer that injection. Either they bring their support person, with them, and so we'll get them scheduled for another visit for the ICI. And then we have all of that information to then send off to the insurance to say they have X, Y, and Z, they meet all of these qualifications, and see if we can get prior auth. I know some offices will keep Xiaflex in the office because we are a small private practice, and that is a hefty, costly medication. I want to make sure that it is going to get approved and that we can get it through their insurance company and through a specialty pharmacy to send it to our office. So again, usually it's kind of that 3-step process is usually what we do in our office.
All right. For sake of time, we got about 3 minutes left. Maybe we'll get to 1 or 2 more questions here. So Amy brings up another good question. So in the trial, we use the entire 0.39 cc, so the entire 90 units rather than the 0.25. So how about you guys today? What are you using? Are you using the full 90 units? Are you separating it out? Lisa, what's your experience?
Yep, I use the full dose. I don't, to me, let's just, I don't know, it's wasting in my opinion. So I want to get the best bang for their buck, and I just use the whole thing.
And it's tricky, but when you document, if you document use 90, wasted none, they will not reimburse you.
No, and I put on there, that I use the whole thing, and that they haven't said anything or come back to me yet. So no, I am the documentation queen. You can ask my billing people, because I never want to have anything in there. So I document that I use the whole thing.
Ken, how about you?
Yeah, similarly, I try to use it, every last bit if I can. I mean, obviously, unless the lesion is that small, but I typically try to use every last bit of it if I can.
Toby?
Absolutely. I mean, we have to do our best for our patients, and I firmly believe that a little bit more medication will treat the plaque more effectively. So why wouldn't I use that? I mean, when these studies are designed, when these protocols are designed, it's a best guess, but that's what it is. And we have these laws where the insurance company will only pay for a certain thing, but ultimately I want to do best by my patients, so I'm going to try to do what I think works optimally, even if it's off-label in that regard.
One other thing we started doing in the past 2 years was we started diluting it down even further to about 0.7 or 0.8, because the problem at Mayo was I had no choice. Like, the pharmacist would give it to you, and that's what it was, But here, because we can mix them up, we started diluting it down, and we've definitely noticed it's a lot easier to get a wider distribution because you have a lot more volume, to administer. So that's the other advantage of, using more of the fluid, is it's not just this tiny little bolus that you may have accidentally injected intracorporeally, before you even noticed. All right, last comment. So from Kristen here, can you describe how to do the penile wrapping and timing to leave it on? So maybe we kind of, from wrapping, of course, head down with it, and Toby had some good pictures there, but what about timing? How long do you tell people to keep wrapping? Maybe starting with Toby.
I have them leave it on for 24 hours for sure, if they can keep it on. And sometimes it'll prevent the hematoma, and sometimes it won't. But as long as they can keep it on comfortably, is what I tell them.
Yeah, thank goodness most are circumcised like the United States, because boy, those just never stay on, the uncircumcised. Ken, how about you? How long do you keep them on?
They're 24 to 48 hours. Yep.
Elise?
Yeah, 24, 48 hours. And I tend to use Coban. I don't know about you all, but yeah, Coban versus the gauze tends to stay on a little bit better for me, for whatever reason.
When we started moving to a 5-day protocol for it. So we tell them the first 24 hours, don't remove it for anything. I tell them, I don't care if the penis is on fire. I don't care if it hurts. I don't care if you got urine on it. I don't care. You don't remove it for anything. Because I give everyone my cell phone. And so sure enough, like at 2 a.m, I'll get a call from every one of these guys when they just get sick of sleeping with it and they take it off and then they get a big hematoma. And then we tell them to wrap it daily for a total of 5 days. So change it once a day after that at the time when you do stretching with it. But hematoma management is just critical, I found. If they get a hematoma, sometimes you'll get a worse curve after it, and they won't stretch. It just hurts, and so they don't do it. So, Toby, turn the time back over to you to close out if you'd like.
Well, thanks so much for everybody for their participation today. I just want to thank again the panelists and give one plug in for the next talk here, if I can find it. Oh, there it is. So Amy Perlman will be moderating the next session on becoming an APP sexual health superstar. And so we look forward to that with panelist Steve Carlson. Elise will make another guest appearance. We'll expect to see several other initials after her name that day, along with Basil Kaki. I think that's how you say that name. So see you June 24th. Thanks for your attendance. Thanks for the questions. I hope you think this was valuable. Thank you to Endo and the SMSNA for making this all possible.
All right. Good night, everybody. Thank you.
Good night.
Thank you.
Thank you so much. Good night.